So what we decided when we talked, and I should introduce Dr. Haddad. This is Dr. Lisa Haddad, who is going to be teaching with me this semester, and it is anticipated that she will be my heir for the educational courses when I do retire, which is, I hope, coming.
Not until I graduate, please.
No.
Okay.
Back to the calendar. What we decided is there are 8 modules in the course. So by the end of February, you need to have done any 3 modules of your choice.
Okay.
Because we did not, again, I looked at the content, and as far as I can see, there's really, things are not dependent upon each other. They're, the different topics are there. But if you're interested in something, or something is particularly needful, fine and dandy. Okay, let's start by looking at the syllabus, and in looking at the syllabus, again, I am reminded that Lisa's teaching with me, and maybe, would you like to introduce yourself?
Sure.
And tell them a little bit about yourself?
Okay, sure. Before I start that, my email is incorrect. So I'll tell you all that now so that you can fix it. It's Haddad L, so you need to add the little L before the @ sign.
Fooey. All right.
Just so if you try to email me, you can. So, as she told you, I'm Lisa Haddad. I graduated from UT with my PhD. I've been a nurse for 20 years, and I just recently graduated. My prior job, I taught last semester here and this semester, and I'm on the tenure track in the graduate program here. I've also taught at University of South Florida in the nursing program, and I've been in the hospital for 20 years. I still dibble-dabble in that at the medical center. I don't do clinical nursing. I was the research coordinator there for nursing, and I still help with some of their studies. I'm involved. My name is just on a lot of them, so I've just stayed on for some of them in a very, very part-time role, but more just to wrap up studies, and I still help them write some stuff, and they're going to be redesignating for Magnet, and they always like writers on that, so I'll probably get pulled into that too. But my clinical background is in ER. I did that for about 14 years. Then I went into education in the hospital setting, and one of the faculty from USF said, "Oh, you should come teach a clinical class for us." And I thought, yeah, sure, whatever. Little did I know, they pulled me in and I taught a class, and then they're like, "You should start the PhD program." And for some reason, I had just finished my master's, had my 4th child, and signed up for the PhD program. I think it was some kind of delusional postpartum, I don't know what it was, but anyway, I awoke to being in the PhD program, and about halfway through I transferred, which is probably another thing that I wouldn't recommend for anybody to do, but I transferred up here to UT, and I finished up here. So, I have 4 kids. I live in Knoxville too. I don't live here. That's why I was a little late. I had to get children to school, get on the road. It's always exciting, so my days I'm here. How fast I can get here.
Well, depending upon, I can understand, because I used to commute from Knoxville as well.
It's a beautiful drive.
It is, but it gets old after a while, I got to tell you. So, especially when you're doing it 3 days a week.
Yeah, that'd be a little bit. I don't come 3 days a week.
That's
as far as contacting me, you can always email me, and the number on here is my cell number. Feel free to call me. I don't work nights though, so if you all work nights, that's fine, and I don't mind having a night conversation, but we'll need to schedule it, because if you randomly call me in the middle of the night, it won't make sense. So I'll answer, but so if that's something you all need to have a late night phone call, I don't mind doing that. We just need to schedule it beforehand. And other than that, I mean, just if you'll be respectful, that is a cell phone. I do have a family, so I'm very open to talk to you all. It's just.
Oh, I'm sorry.
Speaking
I
of cell
forgot to
phones.
turn that off.
It's okay. Things. You might get very good reception, but, well, no, this should be okay. The
Well,
middle
it's-
of the building still has,
It's at least enough for
And
a,
that, that other
text
room, also,
message
that
to
great big
come
room,
through.
or that faculty council.
yeah, it's, there are multiple
where you're at.
dead spots. You know, and the other humorous thing, when they remodeled this building for us, the plans were 8 years old. Because the state never appropriated the money. And you can imagine the 8-year-old plans might have needed modification and they wouldn't let us. So we have all kinds of interesting things that we really didn't need. And then in the computer lab upstairs, it was known it was going to be wireless. So somebody made an inquiry and some of the construction people made an inquiry, and somebody here in the College of Nursing said, no, it's wireless, we don't need outlets in the computer lab. So the outlets and the wiring for the computers were retrofitted. So I guess really, you know, having a broken copier and having a few people less in class isn't really as major an issue when one thinks back to the interesting things that have happened. But the other reason that Dr. Haddad is in the course is that she does have expertise in education. She took a lot of education courses.
At USF, they had an education track in the PhD. Then when I transferred, they didn't recognize that, but I still have all these classes. And really, after I started teaching that first class, I was hooked. It's very interesting to me. And it's all about flexibility. So the fact that the copier didn't work, or I was tardy, or it's all flexibility.
or that I showed up and not
Yeah.
expected.
I'm like, and I apologize. What I was going to do is email you with the link to the thing. So I didn't know you weren't good. So, oh well. All right. This theoretically, this course drills down more from the macro perspective. And remember, I tell you all, that macro perspective was a flyby. And I do again apologize to all of you. It was such a lousy semester.
No, the readings were great.
I hope you got something out of the course, because I sure didn't give you much. But I have to tell you, Angel knows, and my left hand is normal, and my right hand is nearly so. And the problem is petroleum. So I am now fragrance-free, and hand sanitizer, regular hand sanitizer free, because it's a petroleum-based product. And of course I was rubbing it in well all the time. So I'm very thankful because I see an alternative practitioner, and the regular guys had nothing to offer me. So I am thrilled to death. And don't plan on having another semester like that again, ever. But in case, we now have backup. So you will not have to wind your way through almost totally on your own. I apologize. But it's a done deal, and I will be sending each of you a really interesting, I was to say, the result of a really interesting review. Never in a course have I looked at the entire semester of what a student has done. And because of being sick, that's what I started doing at the end. And it's been a real revelation to see somebody across an entire semester. So you're going to be getting a letter from me that, this is what I saw. And it's been very valuable. But I've never done it before. So it's the kind of thing, usually when you're teaching undergraduates, all you do is, you're really only looking at their test grades across the semester. That really doesn't tell you a whole much. Because most students tend to perform at the same level. They rarely change unless they have an aha moment. You know, they stay kind of the same. It really doesn't help you know whether the student's grown any across the semester or not. And that's a shame. So I'm really segueing way off base. So this course tries to look at specific, applicable material and skills. And that's where the emphasis is. But if you look at, and I mean you can read the objectives, but if you look at the topical outline, I'm still starting out with context, but not, I want to say, context in general, but how context has affected each of you in your nursing education practice based on what's happening in the world. So we're going to talk about that today. But then we go down to specific things that, you know, I trust are going to be immediately applicable in your teaching situations, no matter who you're interacting with. But that open module at the end, the reason that's not all loaded up yet is because when we talked about, another group of students talked about what they most wanted help with, these are the topics that came up. Faculty workload. Yeah. Student self-evaluation and their ability to understand their own performance. Student failure and due process, and the issues about dealing with these failing students and whomever else they drag into their conferences with you, like parents and fiancés and interesting moments, and the whole issue of remediation. And so my question to you as we go throughout today, maybe you have something on your mind right now, is there anything else you'd like to see in that open module? Issues that you think affect you? Or that you've stubbed your toe on in the past?
Are you all teaching at this time? You teach? You don't? You teach?
I'm still clinical. I work in a dialysis unit.
I can't particularly think of anything right now. I mean, these are all good issues, but.
If something comes up,
Okay.
yeah, I wouldn't be averse to adding a
Well,
topic.
I'm always interested in the clinical teaching aspect, but I have collected numerous articles.
You've got, yeah, you're already starting your literature search. Well, that's an interesting point. Because we could put some things in there about comparing and contrast. Now I'm doing it. When you compare something, you do contrast it. It is redundant to say comparing and contrasting. So comparison inherently means how is it alike and how is it different. We had a writing workshop yesterday and talked about some of those things. But it might be a really, just to do a brief thing on differences. I mean, some differences are obvious, but differences from the faculty role. You know, what do you as a faculty?
So are you interested in like a clinical educator or educating patients?
Clinical educator.
So educating the staff in the clinical setting?
Like students.
Students, okay.
Because it's such a complex, clinical teaching. That, yeah, no, hold on a second. No, we do not have that anywhere else. But I can also do an emphasis in teacher characteristics and behavior talking about the complexity of the faculty role in the clinical setting nowadays. But there's also the whole issue of all right, we're changing the course as we sit here talking about flexibility. I don't think we need some reading on linking experiential learning, because the trouble with the clinical setting, it's supposed to be the experiential learning, but we're still stuck back on the apprenticeship model for the most part. And that's just not working in today's clinical setting. It's just too complex. We just heard, of course, you may or may not have known about Mountain States is the big, and they laid off over 130 folks yesterday, mostly from administrative levels. And as it stands right now, the other major system in the area has changed their computer system, which means that their entire staff is focused on getting functional with their new computer system. Yeah. So we now have nobody in one system with kind of chaos and changing positions and everything, and how are we going to fit students into that setting? How are we going to let students, identify staff who aren't overwhelmed by everything else that's going on, who are willing to work with them, and the numbers of students we have, and can we have another system that's, not focused on students at all? So, the student experience is certainly at risk in both the major systems that our program is. I wouldn't say, necessarily, but at risk for the value of learning, for them being able to really gain from being in the clinical setting. So that's a topic well worth exploring, and we will do that. Alrighty. If you think of anything else, holler. But those are the modules. Okay. The evaluation elements. There's something else. Yeah, and we are going to try ourselves. Let me ask, have any of you used debate as a teaching strategy?
Yes, I did.
Okay. Well, you're going to try it again. And the challenge is we're going to do it over with technology.
Okay.
And so most people haven't. So so you'll be the expert.
No, I just did it last semester for the first time. It was good.
Oh, good. Well, that's okay. We'll have some feedback on that too. We're going to do that. Debate as a teaching strategy and having you experience it. So that's one of the synchronous meetings that we're going to have. We also decided, Dr. Haddad and I, that we were going to cut down on the number of discussions. Cheers, everybody.
They almost look like, can I smile now? Or
Yeah.
they don't look, seem too excited.
Yay!
It's a good example of falling into a pattern and not critically thinking about the pattern. And when you start teaching online, when we start, everybody talks about, okay, discussion is the major avenue of learning because and that does not always prove to be the case. Because, okay, I got 3 posts. I'm going to get up there and get my 3 posts up. So we decided we would have 3 ongoing discussions across the semester. And I want some feedback from Dr. Haddad before I put those up, because we've talked about possibilities, and I'd like her feedback on a couple of topics that I think we ought to have. But the point being, it is important that you not ignore this aspect of the course, that you do check the discussion board carefully, because it's an ongoing thing. So it's not gonna work to get halfway through the semester and put up, 5 pages of stuff. That won't, that's probably not gonna be helpful. I really want it to be an ongoing dialogue.
It should hopefully build off, your post needs to build off what's already been posted. So keep taking the discussion more in depth and further along. Hopefully we won't see, that was a great post, I really liked your thoughts.
Yeah. Thank you. We know you want to praise each other, but no, we don't want to read any more of those. So that's the plan for discussions. 3. And just,
And as far as I'm concerned, and correct me if you're different, but you don't need to write 5 pages.
yeah.
I don't wanna read it, I mean, I have other classes I teach, and like I said, 4 kids, just put a substantial post up.
Yeah.
It does not need to go on and on and on.
No, but it does need to have significant
Right.
ideas.
And then
Yeah.
that allows for the next person to build off of as well.
So that's one thing that you can smile about. Okay. There will continue to be module assignments, short things that force you to interact with material. That's what they're all about. There will be some additional reflective writing. You will be creating a syllabus, and I'm going to show you the guidelines for all those. And there will be an interdisciplinary teaching analysis. So what in the world is that? I need to change my vocabulary. I think I've used the word interprofessional on a couple of things, but that's what it is. What will happen there is each of you will be looking at the education literature of another discipline in the health fields, and also talking to somebody in that discipline. And we've had a lot of fun with this in the past. It's been most interesting, and we'll see if you guys come up with the same kinds of conclusions that we have reached in the past. The texts, you already have Billings and Halstead and Bradshaw and Lowenstein. They're really, by my way of thinking, is not a good teaching strategies book available. They all treat the strategies in isolation. Here's this strategy. This is what's, use this if you want to for this, this, and this. That doesn't quite get it, but that's what's out there, and I sort of think this is one of the best of the lot. The additional resources are all books that are very, very useful and helpful. The journals are just a suggestion in terms of if you really want to be in the research literature and the literature on education, these are some of the better ones. And some are some of them are changing, but they're some of the better ones. But that's still, any question about that? We'll get into the specifics momentarily. Okay. Here are the guidelines for the debate. All right. We do have, we'll split the group in half. I don't know whether somebody else is going to, there's a tentative other person who might be joining the class. I don't know for sure. I should know by tomorrow whether that person's going to do that. At any rate, it looks like it'll be 2 and 2. Okay, and the debate topic is, they change this after our conversation, but I really have an ulterior motive for this. The debate statement is, the majority of nursing faculty believe tests and examinations are the best way to evaluate student learning. So 2 of you will support that statement, and 2 of you will counter it. okay? And you know, you do want to, whatever resources you choose to get material, fine and dandy. Probably, you know, as much in the literature, if there's any research out there. And I don't know whether there is. I didn't go looking. There might be, there might not be. And if there isn't, then you're going to have to look at other things. But the emphasis in debate is presenting an argument, convincing the persons listening that you have a valid point that is supported and supportable. So think of yourselves as advertising execs, because you want to make your position sound like the best thing since sliced bread. But there are rules to debate, all right? And I was never on a debate team. Were any of you on a debate team? I've heard many, many good things about being on a debate team. But the rules basically say you have a specific amount of time to present your first point. And then there's rebuttal. And then there's a response and rebuttal and a response and rebuttal. Basically, three shots at presenting your position. And the second and the third shots, you get a chance to huddle, because I'll set discussion rooms, or breakout rooms is what the term I want, when we're on Adobe Connect. I'll set your breakout rooms so that you can go into the breakout room and discuss what has been said by the other team and organize your response and then come back and present it. But we'll try to create the actual debate structure in Adobe Connect, which is another challenge. But yeah, I think we can make it work. And then we'll talk about what worked, what didn't work, what did you think, etc. So we do need a date for that one. This is kind of out of order. Okay, we've got a whole bunch of papers here. At the end should be, yeah, I'm sorry. I shifted things. Take those papers that are there. Go to the guidelines for the syllabus creation. And I will be getting to you materials that aren't in the course, that I will mail you materials, or if I can get them copied this afternoon, I'll bring them to you tomorrow. Are you all going to be here tomorrow morning? You're not. I'll mail it. You going to be here tomorrow? Maybe.
Depends on the weather.
Okay.
It's supposed to snow.
And you might, because the
I have
weather
to be
might
here for the
cut out.
last half for sure.
Okay. Well, I'll just mail them to you. Say.
Do they know when is snow coming in the morning or in the afternoon? I haven't said.
I think
Who knows
I
the
didn't
world
hear
every
this
day.
one.
supposed to start tonight.
I thought I heard tonight too.
Yeah.
Then I might head out and come home.
Yeah,
Yeah.
that's,
Instead of
Because
getting
you don't want to
stuck
get
here.
caught.
You
Yeah.
want
Yeah.
to stay here over the weekend?
My children need their mama. My husband needs his mama.
Your
Yeah.
household is falling apart.
Yeah.
They're doing well.
You know, but he's had it by this time in the week.
He does very good.
All
Firm
right.
insight in.
With supper cooked and children.
Oh, that's funny.
The challenges of graduate school.
Yes.
Yeah. You know, I will just plan on mailing it to you. But this is the wrong one. No, this is the wrong one. Okay. What you're supposed to include is correct. You can design the course for either undergraduates or graduates. But the topics, cross the topics out. Everybody's going to be working on a syllabus on a course about nursing image. And I'll get the correct guidelines up there. How did this get out? So, now why in the world, so it's an elective course, obviously. Because people would not be putting that in a regular curriculum. I wish they would, but. A course on nursing image, and you can frame it you can approach it any way you choose. The reason for that choice is image really impacts the public, and we still have a very strong public image. On the other hand, we have some other images due to the media that aren't so good. So it's really very interesting to say, okay, the public trusts nurses, but the portrayal of nurses in the media is very derogatory. It goes back to Dickens and Sarah Gamp. It's about we don't look any better than Sarah Gamp on the media as we're portrayed. It's ridiculous. So, there's some interesting issues related to the image of nursing. And what would it be like if those coming into the profession really understood some of those issues? Especially when you hear those students coming in and complaining about the scrubs because they aren't tight enough. I hate the scrubs. They're not tight enough. Heard that. Actually heard going down the hall. Interesting. All right. So the topic of the course, the elective course, is nursing image. And again, you do anything you wish with it. Okay. Then the other thing to be done is a lesson plan. And you're like, lesson plan? Let me tell you, those in education, regular education courses, K through 12, etc., live on lesson plans. And there is a very good reason for that, because you know exactly what you're doing throughout a day.
And they're especially doing now with those core concepts. Everything is, it has to be documented in their evaluations, their jobs are every year based on
Whether they have their lesson plans. One of the other things that happens is if you have lesson plans, theoretically, somebody a substitute can just come in and take it and do it. Assuming the substitute has some knowledge of the content that's going on. I am unaware of any nurse educator that I have ever known, myself included. I've done many lesson plans, but don't do lesson plans. We go into each class presenting the content. Now, we may have moved to the point where we try to use different teaching strategies. Okay, I'm really going to try to use learner interactive teaching strategies, but it's still, okay, what's the content for today? All right, GI, got it. That's as far as we go. And what you feel about GI and what I feel about GI may be completely different, I may be really into, because I have a sister who's an ostomy nurse, so I'm really into ostomies and patient reaction to ostomies, so that's where I'm going to put my emphasis. And you're thinking, no, I'm into the obesity thing and the kinds of surgeries that are going on to deal with obesity. Those classes can be completely different. What a lesson plan forces you to do, like it or not, is to say, okay, what's really important about what we're gonna do in class today? All right, if these are the really important things, what do I want the outcomes for class today to be, et cetera. So it really forces you to do some critical and careful thinking as a teacher about what you're trying to get across. And this applies to whether you're teaching undergraduates, graduates, patients, staff, doesn't really matter. It forces you to be really clear. So we're going to do a lesson plan. And finally, the guidelines for interdisciplinary pedagogy report. The selections are there. If you want to do, I can't think of anybody else that might be part of the healthcare team. But if you are aware of something that you'd rather do than this list, that's okay too. But the goal is pick one of these professions. Look critically at their teaching literature. That's why this is about the pedagogy. You know, what is their teaching literature like? And there's some things to explain there. Also want you, and this has been very interesting in the past, also want you to interview a member of that profession.
Would pharmacy be okay? Pharmacy?
Oh my goodness. Thank you.
It's okay.
That's embarrassing.
I won't take advantage of it, but I'm married to a pharmacist, so.
Oh, yeah, oh, please, yeah, please don't do your spouse.
No, he doesn't teach, so.
All right. I can't believe that didn't get on there. Thank you so much. All right, and it might be another one that I've missed. But talk to a member of that discipline. And
And they don't have to be in education for that discipline, just a member.
just a member. They don't have to be. And what you want to ask them is, what do they think they contribute to the health of their clients? What, you know, so, and then, what do they think nurses contribute? It's a very interesting interview, I will tell you. So you want to be open, you don't want to ask the kind of question that gives you the answer that they think you want to hear. You want to be really open about it and say, okay, you know, how do you see, your role? And then look at the issues in interprofessional communication, etc., teaching needs that would fit both students in both kinds of fields. And then it'll be a presentation during the Synchronous class meeting. And as I said, this has been a very interesting exercise in the past. We talk about interdisciplinary education, but we often do it without much background. And those who are doing it without an understanding of where students in that field are really coming from. So that's why I want you to look at the teaching literature in the field. And I assure you there are going to be some surprises. There have been in the past. All right, those are the biggies. So we need dates. Because I don't want to let these things just sort of happen. So, what would be a good day of the week? Start there. When are your other classes having synchronous meetings?
This is my only class this semester.
Okay.
Just
So,
Saturdays, I prefer to do it in the week.
Okay,
I wanted to do a Saturday class if I could.
okay.
Thursdays are the days that I had requested off work for the other class that I'm not taking because I can't come on Thursdays and Tuesdays. So, you know, I've already.
You'd love it if it was Thursdays.
You know, that would
Thursday
work
works for
great
me.
for me.
Thursday?
I have
Thursday's
some
fine.
synchronous session in the other class I'm teaching on Thursday, but flow, the way we've divided on the sheet, those are hit or miss, so depending on what days they pick.
Okay,
And
so they're not picked yet.
No, she's picked them. Like March 6th is one, so as long as we avoid the ones I have. And
Oh, yeah, we-
The other thing is I teach undergrad psych clinical on Tuesdays in late February, March. So Tuesdays will not be good.
Okay, well, the Thursdays,
Well, now I can certainly ask off any other days. You
I
know,
work till
because-
7 on Mondays
Okay.
at a clinic, so.
well, Mondays and Tuesdays are not, well, are Thursdays, as long as we're alternate Thursdays
As long
from the
as
other
I'm-
class.
Or
Okay.
Wednesdays. I can do
Thursdays
Wednesdays.
are good.
Thursdays then? Okay.
Well, let's try Thursdays then, all right. Why don't we just identify all the Thursdays that are free?
20,
The 20th
February
of,
20th.
February 20th is free, okay, 2/20.
Does that work perfect?
Well, keep going.
Oh, February 27th.
2/27 is free, okay.
March 13th, but that is
That's break
spring
week,
break.
isn't it?
Yes.
We
that's
don't,
spring
we
break.
don't go there.
March 27th.
3/27, okay.
Okay, now that one I can't do because I'm doing a presentation in Huntington, West Virginia.
Good.
that day.
All right,
So
cross
that
the
would be-
27th off, all right.
April 3rd, but that's Appalachian Research Day, and I don't know if that affects this class or not, but I know that is out there. It affects the other class a little bit.
Yeah, I don't think,
And
we're
I
not
don't know
gonna do
that I
anything.
have to even be there, I'm not entirely sure what that means for me, but. So that, we could do that.
Okay,
April 17th,
or 17,
April 24th,
or 24. And that's where we,
that brings us into May then.
yeah, we really wanna stop there.
Need to get it done.
Okay, we have debate that needs a day, interdisciplinary that needs a day. So let's pick two, any two.
Do you want to do one on 2/27 to knock it out?
And why don't we do the debate on 2/27?
Okay, what time what time are we looking at?
I
Okay,
can pretty much do these.
Any time during the day? I have a doctor's appointment at 3:30 that day. I can do it. I can do it 5 o'clock in the evening, I can do it in the morning, I can do,
Mornings are always better for me than you
I
guys are in
can't, I
school.
have clinicals in the morning.
What time
Okay.
you get out?
I get out at like 1:30.
okay.
So, I mean, I could go to my office and be there easily by 1:30. I can
How
wrap
long
it up.
do these sessions last?
well, we could, if we do it at two, how much travel time do you need?
I will need to leave at 2:30 to get to
Okay.
my appointment. It takes me an hour to get there.
Yeah,
Everything's far away from me, so.
that's not quite,
Well,
half an hour isn't
I could let
enough
them
time.
out a little earlier that day. I'm sure they won't mind.
You don't think?
Isn't that weird how they don't mind about
I
that?
know. I could start post-conference at noon. I usually do, and we usually get out by 1. And then if I just go on campus, it's 5 minutes there. I could be at somewhere by 1 o'clock easily.
Okay. Well, if we had, I think if we had, you'd have to leave by 2:30.
2:30, so if we.
Okay,
could
if
have
we
them
could
about
start at 1,
to
Okay.
2:30.
That'd be great.
we'd for sure be done,
That'd be
okay?
perfect, because even if I pick up my kids, I got time.
Okay. And anticipate now that it being for about an hour, by the time, you know, the actual debate itself has usually, in the past, ran about 30 minutes. By the time you get each rebuttals, 30, 35, and then a chance to talk about it. So it's probably going to be about an hour. So that would give everybody plenty of time. Okay. So 2:20. 1 o'clock is the synchronous debate, and I will set up the room in Adobe and send you the link and put it on the announcement page, the news page. Okay, so it'll be there permanently, and you just log in using that number, okay? All right. How about the interdisciplinary synchronous session?
And that's the one where we present our paper. Is that what?
Well, it's not, it doesn't have to be a paper per se.
Okay, okay.
Smile, y'all. Doesn't have to be in writing.
Okay, this is good, this is good.
We do too.
Okay. So it's not gonna be a paper, but it is gonna be the results of your interview and the
Okay.
report, yes.
Okay,
That you don't, it doesn't have to be,
all right.
So if we
Very
did like
good.
4/17, would that give you all enough time to do all that work, get it prepared?
And that would get it done earlier too, and before any other final papers are due.
Okay.
4/17?
4/17. Now, do we wanna do an evening one then, or, afternoon one? Stick with the afternoon. Could we do it
I
I'm
have a
gonna-
meeting that gets out at 12, so
Okay.
anything after that.
Do you want to do 1 to 2:30? Do you have clinicals that day too?
Yes, I have.
Okay, well, let's start at 2.
Okay.
Let's start at 2 that day, just because, you know, and this, in terms of time, over an hour, but not a lot over an hour. I mean,
2 to
if,
3:30 would cover
probably, is that gonna,
us. My mom can always pick up my kids if I have them that day.
all right.
It's also like moving targets.
Yeah.
Who knows in April?
Yeah, right. Debate, so this is pedagogy report. Excellent. All right, April 17th, 2 o'clock. Pedagogy, and the 27th of February. So those are the 2 synchronous dates that we need. All right. Date. So the other dates that we need to set are the dates for the lesson plan. Why aren't you on there? The debate will have some points by itself. Where? This is. You know, this should have been the right version of the syllabus, but I will have to go change those points. Okay, so there's the syllabus and the lesson plan. What dates do you want to set for those? Those are papers, but
We don't have anything in March.
We don't, do we? Don't have anything at all due in
Okay.
March.
Can we do it after spring break that way?
yes, yes.
Yeah.
Spring break would be a good time to work on it, right?
I've had, when's ETSU spring break?
ETSU's is the week of the 10th, Monday the 10th.
So
Is it
you
the
just-
same?
Yes.
Good.
Work on school.
All right. Well, is that gonna mess up your spring break?
I live in Georgia.
Hopefully, it'll be done before spring break.
There we go. All right. Okay.
Whatever, so the 20th or the 20th?
And we don't have to meet,
We don't
so,
have to meet, it's just a
Okay.
picking
Oh,
a
it's just
date
a
that
due
it's gonna
date.
be due.
yeah, just picking
Oh.
picking a day.
So we've got modules and 3 modules, so we've got pretty much front-loaded with the module work. But we don't want to leave anything much to the very end either, so.
Well, of the two, the lesson plan is going to be, is something that you could tie to something you're teaching or presenting if you choose. That would probably be the lesser of the two evils, so to speak.
So we should do the syllabus first then?
What I was saying, the lesson plan wouldn't be, because you've got spring break week and 3 modules due, so I'm suggesting lesson plan. No, it doesn't mean that you have to wait till the end of the time to do your module work. It just means you have to have 3 finished by the end of March.
Okay.
So again, you can set your own pace. You know, there's not an obligation. The purpose behind that is that there's not an obligation for you to be, you know, okay, I've got to post on the discussion board Tuesday and turn this in on Thursday, and you know, there's not that. You can fit it into your schedule at any time, and you don't wait. No, don't wait till the end to try to do.
I think we're all type A enough that
That would be bad. But I don't care whether you want to do the syllabus or the lesson plan first. You want to do the end of the month? With the modules? Solves, okay? Every day.
She graduated from UTC.
Cool.
With her.
I was telling her funny stories about that. I was one of them when I graduated. They gave you the GRE practice exam, and I was one of them. They said you should never go on. I mean, nice way to teach, right?
Yeah.
And funny enough, she named the professor who said it to me. I was like,
Not one of those, huh?
yeah. I mean, very encouraging, right? I should never go on, but I did go on. How many other people out of my
So
graduating
now,
class I know?
and she still teaches there, so I'm gonna go back and tell her, oh,
Good. Oh, yes. Hooray.
It's just such a negative thing to tell a student.
It drives me crazy when they do that.
It's a terrible thing to tell a student, because I remember that even when I going, like applying to my master's and stuff, I was like, God, they told me I should never go on. Maybe I'm not smart enough to.
So you
Just
should
And I was
know.
not an A
score?
student. I'm sorry?
Just off your GRE score?
Well, that, and I was telling her, I worked on an ambulance service through nursing school, so I was probably not an honor student. I slept through a lot of my classes. I was tired. I'd ring calls all night. So, and I was a C student. I mean, my motto was C equals RN. Why would I need A's? I could get through with C's. Nobody cares if I got an A or a C in OB. I mean, nobody cares, right, after you graduate? And I know that's not the best thing to tell students. But people have life and people have other things going on, and I had to work.
I took my GRE after a 12-hour night shift, and I did not do well on it. But thankfully, my master's program was like, I was like, I'll be happy to take it again, you know. I was just exhausted, and they were like, forget it, you know. Did fine.
To look at a student's grades and a student's score on a test and tell that person,
Don't
And
try
we-
any harder again. I mean, that's a terrible
Yeah.
thing to tell somebody.
and we used to have a faculty member here who on a regular basis told you shouldn't be in nursing.
I heard
To
that
students.
too, because I was tired during the day. You should just drop out of the nursing program. Well, no, I shouldn't. I mean, I could have gotten straight A's if I wanted to, but why? I didn't need to. I passed the boards first time around. And funny enough, some of our A students didn't. So,
You just don't know.
You know, to make a judgment like that is horrendous. You know, it's gonna, don't go there.
sorry, that's why
It's
we're
still,
digressing
no,
over here.
well, but it makes it still just horrifies me because of what we do, that kind of relationship with a student shuts
She was
down
assigned as my
learning.
mentor, and she's senior faculty, and you know, a new person going in, you're thinking, oh, if she's my mentor, this is, but now I'm like, oh my gosh, I can't believe.
Yeah,
Yeah,
and you
on the
watch
other
somebody.
End of the speculum, I've had some wonderful mentors, I have a mentor at UT that I went through a divorce in my PhD program too, which is a lot of information. But I mean, he literally helped me. I mean, I called him one day. I said, I can't afford to even go to school anymore. He said, let me call you back tomorrow. I thought he was going to talk to me about it. He called me back the next day, and he had 2 scholarships. So there are other ends of the speculum that, people will, and I try, as you're grading papers and your students, I try to remember people have lives outside of this, especially in graduate level. So, I had a student last semester who, he had a rough time and he made it through by a half a point that bumped it up to passing, but, I mean, he had other life issues. That doesn't mean they should fail.
And we lose some good folks. So I think we have to be really careful. That's why I think the debate topic is worth, well worth debating. But shall we just say the end for, which do you want due in March? We'll just say it's due, I think I put on the calendar the 30th because that's a Sunday. And rather than the 31st, I put the modules due on the 30th. Do you want either the syllabus or the lesson plan due then as well? Or just put it all at the end of the month? And which one do you want? Pick one, anyone. Flip a coin.
I think the syllabus, because we'll have more time to look at it. I mean, if we know now, that gives us half of January, all of February, and all of March
Okay.
to do the syllabus. Does that make sense?
Yeah. So syllabus due. Gotcha. So then do you want, again, we'll keep the same format and have the lesson plan due at the end of April, the 30th?
Mm-hmm.
Okay. But I would dearly love it, for those of you who are teaching, if you did do your lesson plan for a class you're actually presenting and get it done earlier.
Okay.
Just so you can see that it does have some value. Now, I've asked for a lot more detail on the lesson plan than you might need to use, but just so you can see how valuable thinking at that level can be.
So we're going to talk about generational differences, and what we said during the break was, this became very apparent to me when I was doing my dissertation, and I mailed out thousands of surveys, and I wasn't getting anything back from Gen Y. I mean, it was abysmal. I think I had like 29 out of literally thousands, and my chair kept saying, mail more, mail more. And so then I went back into the literature and really started thinking about why I'm not getting Gen Y. It's because they don't know what mail service is, snail mail. And I gave them the example of my daughter. I told her to mail something. She put it on her bed, and I said, no, you have to take it to the post office and mail it. And she's a gifted child. She's an honored, I mean, she's not a dumb kid, it's just, she didn't know what a mailbox was, other than, hey, mail comes outside of our house and we pick it out of there. Isn't that cool? So if I would have done some kind of online survey, I think I would have seen the flip. I think my baby boomers probably wouldn't have responded, and my Gen Ys would have been. Because that was in several other studies that I found in nursing, looking at similar variables, but they were different, but they had the same thing. One of the studies ended up saying they had to throw their Gen Y group out because there just wasn't even enough to analyze. So when you're going into nursing, and then I also told them the story when I was mailing out these thousands of surveys, there was these 2 young girls trying to use the where you put it on, self-serve postal thing where you put it on, and they couldn't figure out how to measure it and what it was on the screen, and after about 10 minutes it was just not even cute anymore because, they were giggling and I wanted to get my stamps and go. So it becomes very apparent that in teaching and in nursing as a whole, we have to look at how generations respond differently, because and I was telling them, they're going to respond very differently than if you all were Gen Y sitting here, which is now most of our undergrad students are Gen Y. We have a few that are probably Gen X. But they respond so differently coming into class, coming into clinicals. How you talk to them even is differently. because the Gen Ys want to know, how are you going to give me the A? Gen X and baby boomers are more, how do I approach this class to get the grade that I want out of it? So it makes a huge difference. So I start out by what a generational cohort is. And some of it, I'm sorry, you've already heard part of this talk, so you're going to hear
It's been a year.
So it's a group of people who share a band of birth years and have commonly shared events that shaped attitudes and values. So they're the group that have went through the same history, same environmental effects. Overall, for each group, there's generalizations, but there's still individuality within that group. For example, I fit very well into Gen X for most parts of my life, except I can do like canning and stuff, and when I talk to my friends that are my age about it, they're like, you're doing what? So that's more of a baby boomer type thing to do.
Mm-hmm.
So even though you can generally fit into the group, there may be aspects of everybody that go into a different group. So right now we have mostly 3 generations. Now, I actually got 3 surveys back of people that were prior to baby boomers that were actually working in clinical practice. I didn't keep them in my sample because 3 wasn't, but I thought, wow, that means they're like in their 70s and 80s and in clinical practice. I thought that was kind of cool. But typically we have baby boomers, Gen X, and then the Gen Y.
May I ask, when did they stop calling them millennials?
And call them Gen Ys. You can call them either one, but most of what's in the literature refers to them as Gen Y.
Is Gen Y now? That's interesting that they started out with a term and then got switched. Okay.
So the baby boomers are born between 1943 and 1960. They grew up in economic growth, prosperity in the United States, heavily influenced by civil rights struggles, women lib, the space program, Cold War, Vietnam. They're characterized as workaholics. They had a healthy post-war economy and a vibrant job market throughout the 1970s. So they're very optimistic and went at work. They want loyalty and recognition from authority. They challenge the status quo. They adapt slowly to technological advances. And as nurses, they want professionalism and autonomy. It's kind of pretty much describe what you think of that age group in nursing. Usually when I talk about this, people start smiling and nodding because they go, yep, that's me.
Well, what's also interesting that you point out is if you read the literature that baby boomers wrote, this is, yeah, there it is, professionalism and autonomy. The reason behind the theory push for a global theory that covers all of nursing was autonomy, autonomy, autonomy for nursing. So think about it in terms of the literature too. What was interesting to baby boomers and what they were writing about, it explains why some things aren't, you know, you don't even see them in the literature.
Okay, Gen X. We're born between 61 and 79. We were more likely to be either in a dual income home or, if your parents divorced, then single parent homes. And divorce is really, for baby boomers, something they didn't experience on as a whole very much. But come to Generation X and Y, it's more the norm than the not norm. Referred to as the misunderstood generation. Independent with low need for external approval or support. Influenced by Watergate, MTV, latchkey experiences, personal computers, and the internet. My kids find it absolutely amazing that I went through undergrad without computers and high school. I told them when I was in high school, I took typing class and an actual typewriter. And so I was telling my kids this like a week ago, and they're like, well, so if you type and it moves this thing along, how does it go? How do you get to the next line? I mean, something so simple for us. And this was my 12-year-old was asking me. He's like, well, how do you get to the next line? And I said, well, there's a lever. And he's sitting there thinking, he goes, just seems like a waste.
Yeah.
Well, yeah, because in his mind, he hits enter and the thing goes down, you know? I mean, it's
when you really start looking at the generational differences, it's something that's so given to us, they just don't get. Balance in work and life home, motivated by money. Diversity, independence, confident, creative, and comfortable with change and new technology, which it's easier for Gen X in technology, but even easier for Gen Y. Whereas I know back in Florida, when we went electronic and I worked for a large organization, we had several of our very seasoned nurses retire. I'm not learning the medical record. I'm not learning how to document into a computer. I would rather retire. And I don't know what they did after that. Maybe they went somewhere where it wasn't electronic, but you know, that's a huge impact to nursing to lose. I mean, you're talking nurses that have been nurses 30 years, working on a med-surg floor, good nurses. Not going to do it, didn't want to learn it. So, as nurses, the value of work-life balance remains. They want professional acknowledgement for their advances and expertise. This group wants to be acknowledged. And then we have Gen Y. This is a combination of the work ethic of the baby boomers with the technological savviness of the Xers. Self-reliant, family-oriented, fun-seeking, and hopeful. Their influences arose from technological advances. They can communicate with anyone at any time. Isn't that the truth? I mean, really, they just pull out their smartphone and text, Facebook, whatever. There's no reason to leave a message for somebody. They can get them right then. And is that not true in our clinical settings when they're doing, how many times you have to tell them you can't have phones in a clinical setting?
Yes.
And actually last semester, and I'm teaching with the other group, we all have sections, but the head person of the thing says, if you have your cell phone in the clinical setting, you will fail. And they were all like, oh, that's so stringent. Well, because you can't put your cell phones down for, a clinical.
And pay attention.
So, learn differently in that they have a mosaic mode of moving randomly among a series of points instead of a linear mode of thinking. Does that make sense to everybody?
All over the place.
They're kind of all over the place and they can grab this and that, whereas Xers and baby boomers are more, here's something that I have to do, I'm going to get it done, and then I'm going to move to step 2. And then I'm going to get that done and move to step 3. So sort of by our way we're teaching these modules of, you guys choose how you want to do it. It may be an uncomfortable step for you all to step out of how you're, you may be sitting there thinking, ooh, I don't know if I'm going to like this. I kind of like module 1's going to get done and we're going to cross that off and we're going to move to module 2 and then I'm going to do that. So when we said that today, you guys kind of like looked around like, we're going to do what? We get to do it at our own pace. It's going to be interesting. It may feel uncomfortable for you because that's not how your brain has been conditioned to think.
And there are ways of thinking, going from the specific to the general and the general to the specific. Looking at Gen Y, you have to wonder if they're going to be comfortable with either one of those. And it's interesting, when you present content in class, we all present it according to what makes sense to us. And it may make absolutely no sense.
To them, yeah.
To them.
They want a team approach. They want flexible working hours. They need supervision and structure in new situations. Now, some of that may be that they're just newer in the profession of nursing. So it'll take some time to see if that label kind of sticks throughout their career. It'll be interesting to watch. They want a clear picture of what is required of them.
And I don't think that's always communicated clearly.
Right. This is interesting, too, that this is the group that everybody got a trophy no matter what.
Right.
Didn't matter if you were the best or not. You got a trophy because you showed up. So how's that going to impact their careers? Are they going to start expecting, well, she got an award. I deserve an award. I came to work. And you sort of do see that a little bit already. I can kind of see that in some of the things. I showed up for clinical, I should get an A. Oh, I had to actually do the work. So you think about what we're doing, to the younger generations of kids. How's that going to impact as they continue to grow?
Is there any research on whether, how comfortable or uncomfortable this generation is with touching people?
I haven't pulled that out yet, but that would be a very interesting thing.
I'm really curious about that, because they don't mind touching machines. To me, these are the folks that are gonna be gravitating toward critical care areas because all the machines and the technology's there, and that's second nature to them. But again, they're gonna miss looking at the
They sort of forget about the actual patient
When
laying
I
in the bed.
was clinical educator, it was 2006, we had a huge expansion at the hospital and we hired 20 new graduate nurses, because you can imagine as a clinical educator. And so we trained them, we'd send them through all the classes, taught them fetal monitoring, taught them, you know, postpartum hemorrhage, all those, you know, content and all the competency things. After a few months, the doctors came back to me and they were like, so how are things going? They said, you need to teach them how to nurse the patient, not the computer. I'm like, what? They were all in the computer and not in the labor delivery. You've got to be with your patient. Your computer comes second. It was that touch and that prioritization and, you know, getting it done and check their list that they've done. So I had to go back and actually
touch the patient.
yes, and so now I say touch your patient, you know, but you would think that would come, but it wasn't. And there was actually a thing on A1 of our National Nurses Association about teaching new graduates how to be patient oriented and not computer. So I'm thinking, because you know, if you have the problem, usually somebody else had the same problem. So I started looking. Sure enough, we weren't the only ones.
So I mean, that's a fascinating thing, but we have never before, is that I'm aware of, as educators, specifically addressed, you've got to touch. Now, we do something with our assessment course, which is the very first nursing course, and with our assessment course, they have lab partners that they practice all their skills on. So at least there is another person that they have to touch, you know, because we use palpation and the whole night. So they have to have somebody, but this is a peer, you know, touching a peer. And just to watch them in the hospital setting is going to be a real interesting thing. I mean, I think we need specific strategies. I think we have to address it head on, you know, and asking, you know, how comfortable are you actually touching a patient? And you're going to get big eyes.
I know last semester when the very first day of taking my undergrad students into the clinical setting, and now it's a psych rotation. So they're already thinking what they see on TV, and they're thinking when those doors open, there's going to be like people swinging from the ceiling or something. So they're probably a little nervous about that. But literally the doors opened and they were like, and I was like, go ahead, it's okay, you know, like get in the room. And then I kept rotating through the different units, and I would every so often find them like talking to themselves. I'm like, the patients are over there. You need to go talk to the patients. What are we going to talk about? Whatever you want. It's a psychiatric. I'm sure the patients have something to tell you. You know, just go interact with the patient. So, and then, of course, some of the patients were a little more active than others, and, you know, then some of the students did good with it, but some of them were like, they didn't know how to handle it. They just couldn't sit and have that conversation with the patient. So, we've kind of discussed some of the differences in nursing in general and in education with them. So, we've sort of touched on this. Why does this matter? Significant differences between the cohorts. We didn't really mention, I should have probably had a slide in there about those on the cusp. You do have 3 or 4 years there that you're going to have people kind of really sort of could flow either way depending on what subject you're talking about. So you do be aware of, you know, where that cusp is, and it's the 2 years before and after, you know, each group. Unique experiences of different groups can create value difference, gender issues, tension between cultures, problems with team building, difficulties in active participation in general. So on top of all these other, you know, cultural issues we were just talking about, can affect the student to begin with, but then add in the gender group and the cultural issues, now you've really, really makes it difficult sometimes.
Yeah, the values.
And that's just not our
Was that
focus.
Eisner? Did you have Eisner in there? You did. All right. Oh, no, it's not the same one. Never mind. It's a different one. A different Eisner.
Any questions on that?
Just my youngest daughter doesn't want to be a nurse because she doesn't want to touch people. She's like, is there a way I can be a nurse that I don't have to touch people? I'm like, not really. Not really.
Oh, that's fascinating.
Yeah, my 18-year-old is far away from healthcare for the same reason. She's like, I don't want to touch anybody like that.
And we're not, in terms of nursing education, we have talked extensively about varying your teaching strategies, addressing learning styles, but we have not looked at generational values and generational characteristics. I am not, in the education literature,
Yeah, there's not a lot out there. There's not out, if you look at my reference list for my dissertation, because I looked at empowerment, professional practice, authentic leadership, incivility, job satisfaction, engagement, and intent to leave, and then put generational differences on all of those. I probably have 4 generational articles. There's just nothing out there. On generational differences at all, let alone speaking, there was 2 articles that were within nursing.
Which can be a major big difference, impact on nursing education, because where are the faculty in the generation?
That's right.
And where are the students?
Right. And that's why we have to start getting out there that we as faculty have to curb how we're teaching and how we're looking at students. Because it's not, what used to work is not going to work for these younger groups that come in and want to know how they're going to get an A. Or how we're going to get them the A. They're not going to actually do any work, they don't think. But they've never had to. Think about it.
Right.
They've never had to try hard to be the best on the soccer team. They just got a trophy because they showed up.
reality is instant access, not only to communication, but to information, never mind how good the information is. There's no need to evaluate it. It's instant access. What's gonna happen with our chronically ill persons? You know, there's no instant reward there. There's not going to be a good match. On the other hand, we're going to have more and more chronically ill people and more need for nursing care with a population that Gen Yers just don't get. But we're not addressing that in nursing education. We're just kind of cruising. Oh my word. Much to think about. Thank you. Interesting. And we already know that our clinical models aren't working too well. But here's a quick question for everyone. Long ago and far away, there was a kingdom. No. I had started working with another group of education students on a truly comprehensive review of the nursing literature on clinical models. And of course, there aren't that many, but I didn't want to look at only the research literature, but I wanted to look at themes in the nursing literature about the various clinical models. And that article never got written. So I am putting out the word here. If any of you are interested for residency hours, working on that article, I welcome you. I really would like to get it out there because there's certainly a need for it. And at this point, there are 2 or 3 fairly common themes and approaches that aren't going to work, that aren't going to continue to work, but we're still relying on. But it's fascinating to me because the literature from the 1920s has the same themes in it that the literature from the 1980s has. It's most interesting. And I will never forget, as an undergraduate, discovering an article from the American Journal of Nursing from, I think it was 1923. I remember this is so fascinating. Talking about team nursing. You know, we've gone from primary care nursing to team nursing to, you know, to whatever nursing. But the concept of team nursing, which doesn't work because everything's so fragmented, was back in spoken of and tried back in the 1920s. And everybody thought team nursing was the latest and greatest in the clinical setting. No. So, but I would very much, if you're at all interested, holler at me, and we'll start picking away at it, because I really would like to get it out there. Okay, one last thing I want to do. There were some papers that looked like pages of a magazine article, and that's exactly what they were. There are a bunch of them that talks about critical thinking. And what I would like to do, because I indicate that this gets a module activity, so we're going to do this and get a module activity out of the way. Looking at critical thinking in nursing. These are the pages from the articles that are in the module that talk about definitions. So I would, as a group, would like us to look at this literature quickly and look at what are the various definitions of critical thinking, and then to talk a little bit about, okay, if we can't even agree on a definition of what critical thinking in nursing is, how can we possibly teach it? Yes, is that not the value up there, that we're supposed to be teaching our students to critically think? You know, it's all over the literature. And each of you come from different places, but we made the nursing process analogous with critical thinking for lots of years. Lots of books out there that talk about critical thinking in nursing, and when you open the book, it's a book about nursing process. And that's the most ridiculous, utterly ridiculous thing. I don't know why we let people get away with it, but they did. So I'm going to say right off the bat, you're going to say, do any of you think that critical thinking is equivalent to nursing process? Thank you. Did you think when you practice, you don't, and you never do nursing process 1, 2, 3, 4. You do think nursing process in some ways, but you skip a lot of the planning part is like bing, and you're doing it. You don't ever consciously sit down and think, well, I need to do this and this and this with my patient. You just go do it. So, all right, step 1 is, and I have read these articles, of course, long ago and far away, is to identify the common, let's look at the definitions of critical thinking and identify what the common features are, and is there anybody who's got a few unique features. So let's spend a minute or two. Okay. I think everybody's about done. What's critical thinking?
Don't know.
I think that's the big thing. The last article says it doesn't really matter. Let's move on.
We don't know what critical thinking in nursing is. And when you look at all the words used to describe it, you know, probably, would you say was the most common word used to describe critical thinking? One of the most common elements, because it was in just about everything. Yeah, it is a process. You know, it's not something where you stand still, but there's a particular aspect of it where you're applying your mind.
Purposeful thinking.
Purposeful. I'm looking for an A word.
We analyze.
Yes,
It's
yes,
like-
analytical, analytical, okay? That is in almost every definition, no matter what field you're looking at, almost everybody puts that in. It's certainly ongoing and is not necessarily linear. You know, that's real clear. Another word that comes up or something that's is systematic. You know, which means if it's analytical, it is almost systematic. That's almost an automatic thing. But are we teaching your students this? In anything we do? I don't think so. I mean, we just simply don't do it because, first of all, you know, I would have to ask if we even can. You know, can we really teach them? And can we teach Gen Yers who spend their minds engaged with external stimuli? Do they not? Their minds are focused on external stimuli. And we're asking them to go in their head and analyze. Not that they couldn't. That's not the issue, whether they're capable of it or not. But their thinking processes just don't align with the kind of thinking that we are asking for when we say critical thinking. I mean, criticism implies, you know, being systematic, being analytical, following a process, being deliberate. And there's nothing in their worlds, really, that's teaching them to think that way, unless they have a mother like you who's saying, really? Whose fault is it? Let's think about this. It's just not happening. So we've got a population of folks out there whose brains are just not wired to do this. Anybody come up with, see a couple of unique aspects of some of the definitions? Anything strike you?
For me, it was the difference between critical thinking and clinical thinking,
Okay.
and where we want more clinical thinking as nurse educators.
Yeah. There's something, and there are a couple of, and I can't remember now, didn't put the author down. A couple of unique characteristics that were mentioned: prediction and transformation. That's not in every definition. On the other hand, clinical thinking, we would like to be able to predict what the patient's response is going to be. We really would like to know if we do A, we're going to see B. When we're talking about the physiological, that's a lot easier to do. When we're talking about behavior change, that's much more difficult. And the idea of transformation, really nursing is focused on transforming health behavior. I mean, that's, at the bottom line, that's what it's all about. Because the people who come to us with whatever problem it might be, either want to prevent a problem or deal with one that's already there, or control something. You know, if you're talking about chronic disease, you know, I want to keep this thing within my control. So we're talking about transforming. You know, it's an easy phrase. You got to change your lifestyle. Right. How many of us find that an easy process? And it really, we would like to transform. So my point with that was, here are two unique characteristics that are only one definition mentioned, and right now, since I didn't write it down, I don't know which one it was, and those are ones that would be key to nursing. And they're not in most of the definitions. So, yeah, the one, I had to stick that Tanner editorial in there at the end to get you to say all this nonsense that's in the literature. Pardon me?
Just out loud.
Absolute nonsense in the literature about teaching and laying that burden on faculty in addition to everything else that we've got. Let's get real. Personally, I agree with Christine Tanners that we need to understand how nurses think clinically. So we need, whatever the kind of thinking is that nurses do, we've got to get a handle on it. And one of the things that's not mentioned in any, well, take that back. No, it's really not. In any of the definitions, let me ask you, is the whole thing about how the relationship we have with the patient affects our thinking about the patient. But is that not true? If I am, you know, you got to get somebody ready. Discharge teaching. Oh, I love this one too. You know. Okay, here's your piece of paper. You haven't seen the patient in for more than 30 seconds, and now you're handing them this discharge instructions and going home, and you have no clue. How can you possibly think, even clinically, clearly for that patient, because you know nothing about that patient. You have no relationship with the patient. The patient has no relationship with you. Are they going to believe or remember a single thing you've said? And yet, you know, if you've got the chart and there's a checklist, they receive their discharge teaching. Impossible. On the other hand, Emily, you see the same patients. Mm-hmm. You have a relationship with those patients. When you, would you be willing to share with us, talk about what it's like when you have a brand new patient and the way you think about that patient, compare it to the way you think about people you've known for a long time.
Well, with a new patient, you really don't, you're learning the context of that patient's perspective, where the other. Have they known renal failures coming for a while? Has it hit them out of the blue? Do they have a family network? What's their education level? I mean, the whole context of their renal failure. And you cannot, I think you have to be more open, a spirit of inquiry, and you have to open yourself to reflection, because a lot of stuff right there that they say to you is not immediately apparent, that that's what they're really meaning. You have to think on it. You have to use a little bit more, like I say, spirited inquiry and reflection, and think about it. Whereas the patient that you know, I mean, you've already built that rapport and that base of knowledge, and the context of the relationship and the education or the treatment or the therapy that you're doing fits. And so your critical thinking is not so much open to everything as with the new patient. open to what's changed, what's different here in that. So there's a difference in the context and how you reflect and how you make decisions or how you think about. It's not really a decision-making model, although it is. It's more a spirit of reflection and inquiry, to me, is the difference between my two patients.
But there are a couple of those key words that come out. But what you're saying is that as your body of knowledge about the patient increases, you are less open to everything because it's there. It's already there in your mental processes, and you can be more specific.
Yes.
And with the rest of you, isn't that what, when you know patients well, or you know a clinical condition well, are you necessarily open to 1,600 things? Or do you know what you're honing in on? You know what you know, so in terms of being open to different perspectives and views, that's a component of critical thinking in general. Doesn't fit nursing in every situation. So, you know, we are in desperate need of a conceptualization of how nurses think clinically. And it would be a wonderful thing to see some studies on that. That's what I agree with Tanner's perspective, simply because we can take some things from outside of nursing and tweak them and make them fit nursing. But when we're talking about critical thinking, I think it's a whole lot more than tweaking, because we don't understand really how nurses think. And you kept talking about context, and that's another fairly unique component in definitions of critical thinking, is context. And we can't ignore context because that's what our patients are embedded in. So we can't possibly ignore that. So it is a really, when we're talking about one of the responsibilities that has been laid on us as educators, let's think critically ourselves and say, is this something that, you know, is this a responsibility I really want to take on? Is it a responsibility that I ought to legitimately take on? And I'd say no. Just desperate need that we begin to help our students understand how to think clinically. And I always tell you, those of you who haven't done your dissertation yet, do it on something that you really care about. The older you get, the more regrets you have. And my original dissertation topic was going to be on nurses thinking.
That's funny. I was sitting here thinking, should I share this or not? So I actually wrote almost 2 dissertations because remember I transferred. I had one idea down at University of South Florida. I was going to look at nurses thinking and how you decide if you're going to wash your hands or not. I mean, it's so simple. Every nurse has heard it 1,000 times, probably 1,000,000 times. Wash your hands. It's a simple concept. Yet we still make the mistake of, I don't need to do it. And that's what I was going to study on. And then when I came to UT, they accepted me, and then they broke the news to me after I accepted it. Yeah, we don't really like that idea. And at the time, I was like, I got to start over. I bet they told me that because there's nothing in the literature, and they probably knew it. They probably knew I was going to, because I had a whole bunch of decision making, but it was all psychology.
Mm-hmm.
How people make that decision.
Tanner has done some research.
Yeah. think I remember Tanner saying.
in the area, but then she stopped, and really nobody's picked up the ball. And I got talked out of my
I got told
topic.
of it.
Talked out of by my chair, who thought my methodology was way too complicated. So let's just shift gears. And that is one of the biggest regrets of my life, that I didn't follow that path. Because Tanner was just starting to do her research. So the whole point on this is for yourselves, when somebody comes and says, okay, the curriculum's got to change in this way, or we got to do this, or we got to do that, give it some conscious, deliberate thought, because I don't think nursing faculties do that.
Right.
We just, oh, you want us to add that to what we're already doing? Oh, sure, okay, we'll figure out a way. And we don't really do it, and we don't ask ourselves the hard questions. And especially if you're gonna do a curriculum change, you've gotta ask yourself the hard questions. And can we possibly divorce ourselves from content? And talk about thinking and identity and processes, so that we can put people into the work setting who might be able to survive in it. The last statistic that I saw, and this is several years old, is that more than half of new graduates leave in the first year. Has anybody got any?
That's about right.
Yeah.
That's about what I had in administration.
So, hello, you're graduating a class of 100. Good luck. 50 of them are going to be there a year later. If you have questions, holler at us, and I will be working. I will send you an email when I have gone through my whole list of the stuff that needs to be fixed, and of course. But we got the dates. You know about the modules. So basically, we've got a very simple calendar. Now, I have noticed that in D2L, again, all the courses that are in D2L have access to the calendar. So some calendar days that you look on, you'll see something that won't make any sense. It's because of another course. So I just need to warn you about that. Okay. Any other comments, questions?
Do we need to decide if we're for or against tests today? For a debate?
Oh, well, that could be
Oh.
helpful. All right,
Which
sure.
side we should start picking on?
All right. Who wants to volunteer?
Only
Yeah.
4 of us in the class, so.
Right, and well, just
Flip
Deb
coins or
Henry,
something and-
Deb Henry's the other one, so, who wants to work with Deb?
It really doesn't make any difference.
But I'm totally against it. I am.
Then you really ought to do the opposite.
I know. I know. I've even said to our curriculum chair, closed book multiple choice test is not the only way to evaluate students. I've said that several times, so.
Strong relief. All right.
I'm fine with doing either. We were talking about that on the way down.
And I don't think that we're ever, any of us really gonna say, yes, that's the only way to go, so I think
Yeah.
it's as broad as it
Alright.
is long. I don't think.
But keep in mind though.
Well, it's
We
a
have to
debate,
prove
we
ourselves.
have to prove it,
You
yeah.
might feel differently, but look at nursing faculty as a whole.
Yes, I
The
know.
research, the research.
Yeah, nursing faculty as a whole. Well, then I'll just be pejorative. Will you work with Deb?
Sure, I'll work with Deb.
Okay. Deb and Evelyn. Okay.
And we'll support
Angel.
tests.
Okay. And which side do you want to take?
She said she'd support him.
She
and
says
we'll
that
be
she
against
doesn't, she is against tests,
So
so if
you-
they're against tests, then we
So
will
you're
support
going to do
tests.
that the statement is true.
Yes.
It's true, we'll do Xbox.
Okay,
This should be interesting. I'm excited about this.
Good.
okay, all right, we got that. That's a good one.